Hi, my name is Avik Majumdar. I'm one of the hepatologists or liver specialists at Royal Prince Alfred Hospital here in Sydney. And thanks for the opportunity to answer some of your questions about Fontan-associated liver disease. There's quite an extensive list that I've been given, so thank you all for your enthusiasm. I'll try and answer them all this evening. They've been grouped into different headings, so we'll start off with the first group, which is the liver and Fontan. And the first question is, what made you want to study the liver? Well, that's pretty straightforward because it's easily the best organ in the body. Don't tell your cardiologist. No, but seriously, it's a fascinating organ. It's the largest solid organ in the body. It performs a whole host of functions, and it's affected by many diseases, from things like viruses to autoimmune diseases to problems with the bile ducts or the blood vessels that go in and out of the liver. And this results in, leads to looking after quite a diverse number of people with lots of challenging issues, which is fascinating. And similarly, we have a very successful intervention for people with advanced liver disease and liver transplantation, which also is a very challenging part of the specialty. I guess there's also a lot of work to be done in the future, and that's another thing that's really attracted me to liver disease in particular. Specifically, we don't have any reliable form of liver support similar to dialysis for the kidney, and there's lots of different research areas that still need lots and lots of work done to improve outcomes for people with liver disease. The next question is, how are you involved in liver health management within the Fontan community? Well, for the last few years, I've been sitting in a joint clinic with Dr. Rachel Cordina, specifically to assess and manage people with Fontan-associated liver disease and other gastrointestinal complications. And I also see inpatients when they're being brought out of area or from afar. I've looked after patients with Fontan-associated liver disease for several years here at RPA, but also prior to that when I was working in London, and I had some exposure when I was a trainee in Melbourne before that. And hopefully, we can continue on expanding the outreach of liver disease management through initiatives like this. The next question is, can you please start by explaining what the liver is, where it is located, and what is its function in the body? So, okay, we'll start off with what the liver is. So the liver is, again, the largest solid organ in the body. And I kind of think of it like the factory of the body as such. So it's located here on the right side of your body, just behind the rib cage, so it's well protected. Sometimes if you take a deep breath in, some people may be able to feel the edge of their liver, but it's very well protected on that whole right side there. The span of the liver, if you take it from the midway of your collarbone down, is usually between 12 and 14 centimeters. It weighs anywhere between 1 to generally 1.2 kilograms, but up to 1.5 kilograms for most people, depending on your height and weight, etc. The liver performs major functions, and as I mentioned, it is the factory of the body, and its functions range from detoxification, so the liver takes in all the blood that circulates around your gut, so anything you absorb through your gut gets passed through the liver through a large vein called the portal vein. And from there, the liver has many functions, including an immune function, the detoxification function, so to break down things that are useful or that aren't useful or that are toxic, to package away things that you might need for later, like excess sugars, and also to mobilize things or make new things like proteins or sugars in the blood. It's an essential organ, and if your liver is removed or it's not working, the longest you could probably survive is a matter of days before those functions can't be replaced. So people who have what we call acute liver failure, need a transplant fairly urgently, because as I mentioned, we don't have a replacement for the liver unless it regenerates itself. The next question is, why and how does a Fontan circulation impact the liver? I might address this question a bit later on, because there's lots of questions a bit further down about the specifics about Fontan circulation, so I will talk about that. The next heading is appointments and follow-up, and the first question is, what can someone expect when they come to an appointment to have their liver checked? So this will vary from place to place and where you're looked after, but generally it'll involve a combination of blood tests, a measure of looking at the liver, so whether that's ultrasound, which is the most common test. Occasionally you might be asked to get an MRI of the liver or a CT scan, which are better tests, but again, more expensive and not always necessary to need that degree of information. And an ultrasound is usually the first port of call. And then you might have another type of testing called elastography, which might again be ultrasound based, so something like a Fibroscan, or in some places, we don't have very many places in Australia that can do it, but that might also be magnetic resonance or MR based as well, or based on other types of ultrasound. And usually you'll be, you'll hopefully see somebody with some experience in Fontan-associated liver disease who will be able to tie all those bits of information together. Can you explain why, when studying the liver in post-Fontan patients, we undergo a Fibroscan and a liver echo? So a Fibroscan is a way we try and measure how firm the liver is. And Fibroscan has sort of revolutionized the way we do things in liver disease. And it really had its origins in viral hepatitis, which has a very different way of affecting the liver than what occurs in Fontan circulation. But what it measures is how firm the liver is. And for people with viral hepatitis, that usually is due to fibrosis or early scarring on the liver. And fibrosis can affect people's livers on a spectrum, so early scarring through to moderate scarring to irreversible scarring, which we call cirrhosis. And that's a question that's posed later again, and I'll talk in more detail about what cirrhosis means. But you have these various stages of fibrosis that can occur. And Fibroscan measures basically how firm the liver is. The firmer it is, the more likely it is that you've got fibrosis, advanced fibrosis or cirrhosis. And it gives us a number that we can try and quantify or try and relate to what we normally see with a liver biopsy in terms of the degree of fibrosis or scarring. Now, that's very different in the utility of, or the ability of us to, for us to interpret Fibroscan is very different in Fontan-associated liver disease. And that's because the back pressure from the heart, or what we call congestion on the liver, so blood not be able to get out of the liver, actually increases the stiffness of the liver. So as mentioned, all Fibroscan tells us if the liver is firm or otherwise stiff or not. And we can't differentiate whether that increased firmness on Fibroscan is due to congestion, so too much blood in the liver, or fibrosis or scar tissue. But if the Fibroscan is low, so if it's in the single figures, for example, that's reassuring to say that there's neither congestion nor fibrosis. But it becomes a lot more challenging to interpret in Fontan-associated liver disease when we're at that higher end of the Fibroscan readings. The second part of that question was a liver echo, and I'm assuming that means an ultrasound. So the Fibroscan doesn't give us an anatomical picture of the liver. It doesn't tell us what the liver looks like. It just gives us a number. And the things that you might see on the screen with Fibroscan actually relate to the quality of the measurements and how the machine is calculating that number, as opposed to an ultrasound where you get all the jelly put all over your abdomen. That gives us a lot more information on how the liver looks, whether there's nodules that have formed, and that's very important in Fontan-associated liver disease, or whether there might be a suspicion that there's increased pressure in the veins around the liver. The ultrasound also might give us an idea if there's any masses in the liver, or if there's anything else going on, say within the bile ducts or the gallbladder, that might explain abnormal liver blood tests. The next question is, at an appointment with the hepatologist, my child also had their spleen checked. Why is this done? So the spleen can enlarge in chronic liver disease of any sort, let alone in Fontan-associated liver disease. And it's a marker that there's increased pressure in the veins around the liver. And we'll talk a bit more detail about that. But the spleen is checked during a routine ultrasound, so they'll try and make an assessment of the size. There's an area for research in measuring how firm the spleen is with Fibroscan or other forms of elastography, as I mentioned before. So like we measure that with the liver, you can also measure it in the spleen, and that might gives us an idea whether there's increased pressure in the veins around it if the spleen is more firm and congested. So the next question is, how long after a Fontan should a patient have an appointment to check the liver? So that's a really good question. It's a difficult one to answer directly. We do know from studies that have biopsied patients at various stages after Fontan or Fontan completion that everyone develops a little bit of liver fibrosis. So whether that's early fibrosis that's reversible or through to late stage cirrhosis, the time since the Fontan is the biggest predictor of how much fibrosis you might develop. Generally, these changes of fibrosis happen over time. They're not things that happen acutely, so they take several years to accumulate. And so normally, there's evidence to suggest beyond about 10 years since Fontan is when you start seeing more significant liver disease develop. But then again, as you're all aware, everyone's very different and unique in the Fontan community. People have had different operations, different journeys to get to the Fontan circulation, and very different anatomy. And they're all things that that influence the degree of liver fibrosis. And similarly, I guess the initial sort of trigger that there might be something wrong with the liver before that is often given away by abnormal blood tests. But certainly, within 10 years, you should try and see a liver specialist after the Fontan. And usually in the pediatric setting, it's not as common, but certainly in the adult setting, then everyone should see a gastroenterologist or a liver specialist at some point. How regularly should liver checks be done on Fontan patients? Again, this depends on the situation. I wouldn't suggest that there's a lot of point to be really regular about it until later than 5 to 10 years, depending on the age of the person, and also the other coexisting factors that might influence liver disease. So as people age, they might put on weight, and becoming obese is actually a big problem when it comes to liver disease. Similarly, alcohol or viral hepatitis risk factors or any other coexisting liver diseases, things like hemochromatosis, they're things that you certainly need more follow-up than average. But if your cardiologist tells you that everything's working perfectly well and there's nothing to do, then an annual check is usually an annual check with a liver specialist or gastroenterologist is indicated. And again, that's more important for adolescents and adult people with Fontan rather than in the immediate period after the Fontan for young children. The next question is a very good one. If I have to have a liver biopsy, what does this entail? So we can biopsy the liver in 3 different ways, and I guess the reason why you would go on to have a liver biopsy is to actually find out what's happening in the liver. All these tests that I've mentioned so far just give us an idea, but they're not as good as actually having a piece of the liver under a microscope to tell us what the damage is as such. And that's very true, or specifically true for Fontan-associated liver disease, because the non-invasive tests that we do use have all been validated and developed in other conditions, particularly viral hepatitis, which behave very differently to Fontan-associated liver disease. So the most common way of doing a liver biopsy is through the skin. So with local anaesthetic next to the rib, or through the bottom part of the rib cage, as a radiologist or a gastroenterologist will get an ultrasound and put some local anaesthetic in, and then watch the needle go into the liver and take a couple of samples. That is less common in people who've got Fontan-associated liver disease, mainly because if there is a potential, the risk of bleeding is quite low, but if there is a bleeding issue, it can cause significant problems, especially if people are on blood thinners or anticoagulants. So the more common way is something that we call transvenous biopsy in people with Fontan circulation, and that's accessing the jugular vein here in the neck, which connects straight from the back of the heart through the liver, and putting a long sheath with a needle down there, and then taking a few cores of liver tissue that way. The advantage of it is that that's actually less traumatic, and if any bleeding happens, the bleeding actually goes back into the vessel. So that's a safer way. It's not as good to find large parts of liver, but it's usually adequate for reporting or finding out what we need to know. The third type of way of taking a liver biopsy is through a specialized endoscope, so through the mouth into the stomach, and then again, with this endoscope has an ultrasound on the end, so the endoscopist can view where the needle is going into the liver through the stomach wall. Again, that's a little bit more risky in the Fontan circulation, mainly because if the liver is very congested or the blood thinners can't be stopped, if bleeding is going to occur, it's going to cause more problems. But generally, liver biopsies are very safe and well tolerated, and we still use them, not infrequently in hepatology practice, but something that you can discuss more with the people who are organising your liver biopsy. The next question is quite specific about someone's son. And basically it says that someone had an echo, the results were positive. He has a needle phobia, so the cardiologist deferred a blood test to check the liver. Can a Fontan echo produce good results and the person present with no observable issues but still have a decline in liver function? If so, are there alternatives to blood tests to check liver function? So I guess there's a couple of different things that are teased out. So firstly, the function of the liver is only really measured by blood tests until there's very late stage signs that we can pick up on examination. So by the time we can see signs of liver disease at the bedside, the liver disease has progressed quite significantly. So the point of blood tests is to try and be aware of those problems earlier on than before we can see them at the bedside. So the blood tests are important. The reason why we might not see much of an abnormality and there still be significant liver disease is because of the reaction that occurs in the Fontan circulation. And there's some specific questions later on about what's actually happening in the liver. But essentially what we're trying to find out is there any chronic fibrosis, so long-term scar development from the back pressure, predominantly the back pressure, or congestion related to the Fontan circulation. And that isn't done very well by blood tests. That's better done by the things I've talked about, so Fibroscan or ultrasound. So in your son's setting, I guess an ultrasound will give a good general picture of what's going on, and a Fibroscan also may give a good general picture of what's going on. But they're all parts of the puzzle, and ideally a blood test would be very helpful to confirm those findings. As I did mention, the Fontan circulation is very individual, and the way people develop liver-related problems is also very individual. And so, although the last echo might have been positive, it's really what's happened over time since the Fontan that really dictates what happens in the liver. So if the echo was good, then yes, I'd be reassured that the liver disease was mild or slowly or not progressive, but it's something that you need all the pieces of the puzzle to make an accurate assessment. So I hope that answers that question. What is the process of monitoring liver function if your child has blood test results showing elevated liver enzymes? Again, it depends on what the pattern and what the cause is. The first approach, so if I'm referred someone new, other liver diseases can still occur in people with Fontan associated liver disease, so to make sure that there's no coexisting factors that might influence that. And then it's looking at what that pattern of liver function abnormality is. And depending on the severity, I might order further testing like a CT or an MRI scan, and go from there. So if things are abnormal, then you probably need to be seen more frequently potentially. So that could be 6 monthly, could be 3 monthly if there's something else going on, or if things are just minorly elevated just outside the normal limits that have been established so for several years without any changes in any of the other tests, then a 6 to 12 monthly review might be appropriate. So again, it's all individualized based on the situation. The next question also is very specific to a specific case. So I'll try and avoid most of the details and try and answer the general principles. I guess with these very specific questions, they're best sort of addressed with your actual specialist team. As I might be giving you the wrong information if I don't have all the information in front of me. But essentially, the issue has been again, someone's son who's 14 years since Fontan, and the issue has been elevated bilirubin levels. Bilirubin is a pigment in the blood that's made from the breakdown products of red blood cells, and the liver recycles those products and makes them into bile, which you need to digest fats. So elevated bilirubin, there's lots of different causes. It can be from excessive breakdown of blood cells. There can be a problem with the liver making bile itself, and then putting bile into the small intestine. So a problem with the plumbing itself, so the tubes that connect the liver to the small intestine. So it really depends on what that pattern is. There's a very common condition called Gilbert syndrome, which is a non-pathological condition, so it doesn't have any, doesn't cause any long-term problems, but it's a mild form of high bilirubin that might fluctuate when you start new medications or under stress. And that's because of a lack of an enzyme that conjugates bilirubin, which just makes it from water soluble to fat soluble. And that process is done within the liver. So Gilbert syndrome affects about 5 to 15% of the population. And so that might be the reason why this wasn't investigated further. But again, I guess if there is concern, then you should be assessed by a liver specialist. And again, talking to your pediatric cardiologist is the first port of call. There's quite a few other questions as part of that one, but the last one in that series was that around the same time as the high bilirubin was first noticed, my son was finishing up with his pediatric cardiologist, and is now being in the process of transfer to the adult service. Should he see a liver specialist as part of his routine ongoing checkups? Generally, that is advised, and I guess I'm a bit biased because I am a liver specialist, but I think it's important to see somebody who has had some experience in the area, as there is a lot of nuance and a lot of specific things that are involved in assessing the liver and Fontan associated liver disease. That's very different to routine practice for liver diseases in general. So I hope that makes sense. And as mentioned, it's more important in the adult service than it is, say, in the pediatric service, mainly because the risk for developing progressive Fontan-associated liver disease is related to time since the Fontan itself, the Fontan operation. The next question is also very specific to someone's daughter this time, who's 4 years post-Fontan. And again, the two themes here are protein-losing enteropathy and about whether fenestration should be open or closed. Again, these are very contentious issues, and it really needs to be considered. What was actually, what your daughter's anatomy is, and what the right thing is to do. Protein-losing enteropathy, so it's losing protein through the gut, is often independent of Fontan-associated liver disease. So the two might coexist, but sometimes protein-losing enteropathy might occur separate to significant liver disease. The role of fenestration is something that's very, very specialised, and when to close and when to open those up is really dependent on your cardiology team. So your cardiologist and other surgeons, and usually they of course discuss this in multidisciplinary settings where there's particularly complicated or complex cases. So that's I hope that's answered the theme of those questions.